The data reveals a contradiction in pediatric ophthalmology. Surgical interventions for strabismus are falling, even as pediatric populations continue to grow. To identify the source of this divergence, we have to look at the baseline demographic shifts occurring over the last decade. This chart tracks the Australian population from 2014 to 2025. The trend is clear, a steady climb from 23.6 million people to 27 million. That represents a 12% increase in the baseline population, creating a larger pool of potential pediatric patients. However, the clinical data for total strabismus surgeries during this same period shows the opposite trend. Surgical interventions dropped from 2,482 in 2014 to just 1,613 in recent years. This constitutes a 29% decrease in surgeries since 2019. These diverging trend lines suggest a widening gap between the prevalence of the condition and its clinical treatment. Strabismus is not becoming less common, nor is it resolving naturally within the population. This is a systemic failure in clinical detection. Cases are currently going undiagnosed. ESO deviations are actively obscured during standard clinical observations. The patient's own neurology generates a masking effect that hides the deviation from the examiner. This masking leads to significant delays in starting and completing effective treatment plans. For children, these delays in structural intervention result in negative, lifelong visual outcomes. When the opportunity for timely treatment is missed, the patient faces permanent visual loss. Timely intervention makes this specific form of visual loss entirely reversible. Understanding the biomechanics of motor fusion is the only way to unmask these hidden esotropias before the damage becomes permanent. The physiological drivers of esotropia are rooted in the neurological commands sent to the extraocular muscles. Uncorrected or undercorrected hyperopia is the most frequent primary driver. Hyperopia places an excessive demand on accommodation, which reflexively forces the eyes into abnormal convergence. A secondary cause is anomalous innervation. This is seen in the adduction null associated with infantile onset esotropia, where the neurological resting state of the eye is shifted inward. These red neurological vectors illustrate the constant drive pulling the eyes inward. To prevent double vision, the brain employs horizontal motor fusion to maintain binocularity. This counteracting signal pulls the globes back into alignment, overpowering the inward drive. This results in a clinical presentation of orthotropia, eyes that appear perfectly straight. Motor fusion effectively masks the underlying pathology during a standard static observation. Constant motor fusion exerts a physical toll on the ocular anatomy. The medial rectus muscle bears the weight of this chronic mechanical tension. We measure the health of this muscle through its tension length, or TL, ratio. In a healthy state, the medial rectus maintains a TL ratio within this optimal green zone. But the constant compensatory firing of motofusion subjects the muscle to relentless tension. As these tension forces accumulate, the TL ratio ticks upward, out of the safe zone. Chronic overwork causes the muscle tissue to thicken and become stiffer. Eventually, the muscle permanently loses its elasticity and becomes physically shorter. The medial rectus enters a fibrotic state, and the TL ratio locks into a red deficit zone. Increased demands on horizontal motor fusion drive this structural remodeling. This process accelerates if the quality of the patient's horizontal motor fusion is reduced. Functional neurological compensation has resulted in a permanent structural defect in the architecture of the eye. Static observation cannot detect the underlying tension within the medial rectus while motor fusion is active. The clinician must disrupt the brain's compensatory mechanisms to see the true state of the eye. This requires dissociating examination techniques. Dissociation is achieved through alternate cover tests, the Maddox rod, prism challenges, and prolonged patching. These tools strip away the brain's ability to lock the eyes together, revealing the latent deviation. Only by disabling motor fusion can the clinician observe the pathological resting state of the muscle. The base-in, or BI prism challenge, serves as the definitive test for fusional reserve. Measuring the near BI fusional reserve exposes a patient's latent predisposition to esotropia. By bending the optical path with a base-in prism, we test the eye's ability to maintain fusion against an outward deviation. A normal, healthy system possesses a significant fusional reserve. A healthy result is greater than 20 prism diopters. There is a minimum threshold required for clinical safety. Safety is maintained as long as the reserve remains above 5 to 6 prism diopters. Below this threshold, the patient enters the almost ET state. When the reserve drops to just 1 to 2 prism diopters, motor fusion fails, and the eye snaps into a visible esotropia. Active dissociation identifies this almost ET state before permanent fibrosis occurs, allowing us to catch the cases currently